Mahesh Shanmugam on the retinoblastoma management and mistakes. He's a great teacher, and he's one of the greatest assets. I take it as though people may not. He's one of the few PhDs apart from ophthalmology. There are very few PhDs in India with ophthalmology, and he's one of the earliest one to accomplish this. And his passion for research shows that his desire to complete the PhD. Within 4 years, sir, he completed. How much time it took for PhD?
Yeah, around 4 years.
4 years. 4 years is a great for part-time PhD. It's not full-time. He's practicing, surgery doing, and in 4 years he finished his PhD.
You were part-time or full-time?
Thank you, Dr. J.K. Reddy, for the kind introduction. These videos were working in the morning. Videos are not working? Okay, fine. Sure. Let's start with this child. This child, like one of my colleagues sent this video saying that this child sustained a little bit of trauma. And I can see that little thing floating behind the lens looks partly like exudates. So I thought it was probably a vitritis or possibly an endophthalmitis, post-traumatic. And children, they fall over things and then even a needle can poke inside and create an inflammation. So they want to do a vitrectomy. So I said, try to do a vitrectomy in this child. But then you dilate the fundus and see, ignore this, this is the light reflex from the fundus camera. What you see is this cloud of white tissue which is out here. And if you go back and see, the eye is quiet. Let's go to another child before we go back to this. This was a 4-year-old child which presented to the primary center with white reflex, and when the child presented there, it had hypopyon, vitreous exudates, and made a diagnosis of endogenous endophthalmitis, and had undergone a diagnostic vitreous biopsy, and the PCR was positive for eubacterial genome, so they thought they were right, and the inflammation kept coming back, so the child underwent a vitrectomy twice. Then they thought it was fungal endophthalmitis, and subsequently developed secondary glaucoma and underwent a third vitrectomy of lensectomy, vitrectomy, and repeat biopsy. And subsequently, some point in time, they took the biopsy specimen and sent it for a cytology, which came up as acute lymphoblastic leukemia. And then the child came to me, this is under GA, I'm not doing anything, just putting the light there. What you see, this plume of cells which are coming up is a convection current throwing up those large cells. On the surface of the iris, we can see these deposits. So what it is actually retinoblastoma. And if you were to do an ultrasound on this, it could see a very small tumor very, very anteriorly. It doesn't have the classic features of retinoblastoma like calcium and all that. And the CT scan, the MRI shows a very, very small lesion, which is hyper-intense in T1 and hypo-intense in T2. A simple AC tap in this child showed that the child indeed has retinoblastoma. This child had had, as I mentioned, 4 vitrectomies. So this talk is about these patients where mistakes in diagnosis and management can be rather common in retinoblastoma if you don't know what you're looking for. We'll go back to the first child. Were there clues? Yes, there are clues. You can see the eye is perfectly quiet. There is no conjunctival congestion. There's nothing is there. The child is perfectly comfortable. If it was an endophthalmitis, something should be there. A CCC should be there. Child should be uncomfortable. The child is perfectly comfortable. So in such a situation where the eye looks totally uninflamed, what looks like an exudate inside, look a little bit more carefully. So these 2 children actually have what we call as a diffuse anti-retinoblastoma. This is the one which can be mistaken to be endophthalmitis or an inflammation. And this is just about 1 to 2% of retinoblastomas. It's usually unilateral, and the children are a little older, 5 to 12 years of age, and it's a very small anterior tumor, which may or may not be picked up on imaging, and it sees the vitreous ciliary body, anterior chamber and angle, and they commonly present with hypopyon, uveitis, increased intraocular pressure. And interestingly, even after enucleation, many times you may not be able to identify the tumor even on histopathology. The tumor is so anterior and so small. Most eyes would need enucleation. Very few eyes have been saved. And the child which I showed, which had undergone 4 vitrectomies, actually, like we tried saving, it got better a little bit for a few times, but it kept recurring. So ultimately, we had to enucleate that eye as well. So this was in the interim period. This is how the child presented. You can see after the AC tap and just 1 injection of melphalan, the edema has gone away. The cornea is clear, you can see inside the eye quite well, despite which you can see these multiple deposits in the retina, which came under control, but subsequently because of multiple recurrences, we enucleated the eye. So let's look at another example. This is a 6-month-old child with esotropia. So what do? It's a pseudo-esotropia, looks like almost, isn't it? Give glasses, watch, or do something else. Most important, what people miss, even pediatric ophthalmologists, even retina specialists miss, is to do a fundus examination. A 6-month-old child, it's a little difficult to put the drops, dilate and see, but then it's extremely essential, particularly if a child presents like a squint. So what this child had was a tumor, was a retinoblastoma. You can see the dilated feeder vessels and some amount of exudative retinal detachment. We managed to save this eye, but then very, very important in a child when it presents to us with whatever complaints, it could be a squint, please dilate and we need to examine the fundus. The common confusion, so this is a child which presented with exudative retinal detachment. You can see a lot of these exudates and also see this classic vascular malformation which is suggestive of Coates. So in Coates, this is what we do. So you can see one needle here where I inject into the vitreous cavity, another needle is a 26 kH needle. Now I do a transconjunctival drainage where we inject in one side and drain the retinal detachment, reattach the retina and do steroids. I usually inject deposteroids like a Dex implant or in IVT and subsequently do laser photocoagulation. And these are the results which we can achieve. The exudates going away slowly, and this child had 6/18 vision. But then going back to that previous child, which looked like Coates disease, when we imaged them, so this is what we find, calcium and retinoblastoma. So rarely, retinoblastoma can also present like Coates disease with Coates disease like malformation, vascular malformations, and we need to image every child to make sure that we are not missing them and base the diagnosis just on clinical diagnosis. So what are the features which indicate that it's retinoblastoma? This is one other child where you can see the retina is right behind the lens, and these are the patients where we have confusion, whether it's Coates or retinoblastoma. You see these white lesions here. So these white lesions are intraretinal. So when we see this white thickening of the retina, which is full thickness, which may extend up to the blood vessel, this is retinoblastoma. Because in Coates disease, all the exudate is under the retina. There's nothing in the retina. It's just a vascular malformation in the retina. Other than the fact that it is leukocoria and xanthocoria. Xanthocoria is what you find in Coates disease. We look carefully for this white lesions which involve the full thickness of the retina. It's most likely it's retinoblastoma. And again, this is the imaging characteristics. Coates shows a ground glass-like appearance, and ultrasound shows blocking of the sound waves. And because of the calcium, but in Coates you can see subretinal deposits, you can see the deeper walls of the eye. And this is one such child where you can see the retina is right behind, and you'll keep focusing here, you see these deposits, these cells. So this, I thought it was Coates disease, and did examine under general anesthesia. During general anesthesia, I found these cells which were there in front of the retina. So I changed my diagnosis to retinoblastoma and enucleated the eye. And what happened? And like I thought this is the total retinal detachment closed funnel and possibly a mass lesion. And yes, of course, I didn't enucleate, but then thought it was retinoblastoma, gave 2 cycles of chemotherapy, no response, and enucleated the eye. And post-enucleation, what it came up as Coates disease. So I've been managing these patients for the last 25 years. Despite that, at the end of 25 years, you can still go wrong. That's a point of this particular case. Another thing is, whenever you're doubtful whether it's retinoblastoma or Coates, and it's usually a sightless eye, best would be to enucleate the eye rather than try doing something like drainage and make what is essentially intraocular disease extraocular. Children can present with orbital cellulitis post a fall from a bicycle or something like that, and it's essential even in this situation to image these children, because a retinoblastoma can undergo spontaneous necrosis and set up an orbital cellulitis-like reaction. So that is what this is. This is retinoblastoma presenting as orbital cellulitis. This will settle down with just steroids, and following which we should be able to see the fundus. So this child did have a retinoblastoma inside. The spontaneous necrosis because of when it outgrows its blood supply. So in this situation, we give systemic steroids followed by enucleation. Most often, these children have high-risk characteristics on HP, so treat them with adjunctive chemotherapy as well. So retinoblastoma can present as unilateral glaucoma and unexplained phthisis. So when the tumor outgrows its blood supply, orbital cellulitis, and subsequently it can be unexplained phthisis as well. So unexplained phthisis, better would be to image, and if you find calcium, better to enucleate these eyes, because phthysical eyes with retinoblastoma have shown active tumor cells inside. So I would usually enucleate these eyes. And it's rare for retinoblastoma to present with cataract, but then when the tumor is touching the lens and or has to set up an inflammation, it can. Opaque media in a child, as in this child with vitreous hemorrhage, imaging is particularly essential. So to summarize, retinoblastoma can present atypically, particularly the diffuse anterior retinoblastoma, which can mimic an endogenous endophthalmitis. Whenever there are atypical features, suspect RB, and in a child, always a thorough examination is particularly essential. A fundus examination is particularly essential, and imaging in opaque media in a child. Thank you very much.